Dr. Muhammad,
Yes.
start.
Yes. Good morning, everybody, or good evening, according to your time zone. On behalf of Essential Group, we are pleased to welcome you on this scientific activity dedicated to advancing knowledge in clinical practice in critical care medicine, especially respiratory critical care medicine. Today, we are honored to have two distinguished professors and expert in the field of critical care medicine and respiratory critical care medicine. Both of them are from Italy. Professor Giacomo Bilani, one of the most distinguished figures in the field of respiratory critical care medicine, and Dr. Giacomo Gracili in University of Milan. I will not talk too much, and I will handle the mic to Dr. Giacomo Bilani, who will introduce Dr. Gracili and the topic today. You are welcome. The questions and answer can be sent through the chat, question and answer in the chat group, and we will have some time to discussion after we finish our talk today. Thank you very much again, and hope you will enjoy our talk today.
Yes, good afternoon, and thank you so much for inviting me as a moderator to this session, this series of webinar I was previously the speaker of. And yeah, today it's my great pleasure to introduce Giacomo Grasselli from Milan, Italy. Giacomo and myself have been friends since a long time. I think we were residents more or less 20 years ago together, and we've been colleagues and friends since. And now I'm based in Trento, and Giacomo is chair of anesthesia and critical care in Milan. It's the institution where Luciano Gattinoni has been chair, and then Antonio Pesenti, and now Giacomo is. Giacomo is also, I say this because he's humble and he won't say anything about this, but Giacomo is also the incoming president of the European Society of the Italian Society of Anesthesia and Critical Care, CIARTI, and he's just been the secretary of the European Society of Intensive Care Medicine, and he's also the first author on the European guidelines recently published on ARDS. So I think without further ado, I hand it to Giacomo, and then we will be happy to share questions and challenges with him.
Thank you. Thanks, Giacomo, for the introduction, and thanks to the organizer for inviting me. It's a pleasure to be here. Welcome, everyone. So my topic today is to discuss the new recently released ARDS guidelines and compare the indication from the European Society of Intensive Care Medicine and the American Thoracic Society guidelines. Okay, these are my disclosures. And so these were the first guidelines that had been released jointly by the ESICM and the ATS in 2017. And as you can see, so this was a joint process, and the aim of those guidelines, and Giacomo was an author of those, I think, was to answer 6 questions that you can see listed in these slides. Since then, the guidelines had never been updated until 2023, when the ESICM decided to release its new guidelines. And then immediately after that, the ATS published its own guidelines. So these updates are not joint between the societies. And these are the 2 main publications. So the European Society of Intensive Care Medicine guidelines have been published at the end of 2023, beginning 2024 in intensive care medicine, while the American Thoracic Society guidelines have been published a few months later in the Blue Journal. These are the authors of the European guidelines. So the process was started by the ESICM leadership. Maurizio Cecconi was the president at the time. They appointed three co-chairs, myself, Caroline Calfi and Luigi Camporota, and one methodologist who was Daniele Pool. We had to identify a relatively large number of experts, almost 61, plus 8 patient representatives and family representatives. They were invited to participate in voting and reading the manuscripts. So we identified 9 domains and in total 16 PICO questions. We analyzed only randomized control studies, only performed in adults, and articles only published in English. We decided to exclude pharmacotherapies, except for neuromuscular blocking agents who were considered as adjunct to the ventilatory management of ARDS. So the focus was the topic. The idea was to focus specifically on the ventilatory management of ARDS. So the process started in 2022. So we decided to answer specific questions on COVID patients. And of course, we wanted to follow a strict grade methodology. Each group provided its own PICOs and then its own statements, and then the statements were discussed in panel-wide meetings. And then in the end, there was an anonymous voting on the recommendations, and the threshold of 80% of agreement was selected to adopt, to give a positive indication on the recommendations. So the main outcome was mortality. So we decided to analyze mortality at 60 to 90 days when available, or let's say mortality at the longest time point available, because we consider that hospital or long-term mortality were more relevant than the simple ICU mortality. And then, of course, we had other outcomes that were selected within each domain and selected based on the risk of bias. So, for example, let's say for domains who are analyzing non-invasive respiratory support, intubation rate was an obvious secondary outcome. And for other domains, the days free from mechanical ventilation, duration of mechanical ventilation, and ICU length of stay or hospital length of stay, and also some selected adverse events. For example, for the PEEP and recruitment maneuvers domain, the risk of barotrauma was an important secondary outcome. So these are the 9 domains. As I told you, 16 PICO questions. We ended up with 21 recommendations, and as I was saying, specific recommendations for COVID-19 patients. As you can see from the list of domains, the first 2 domains, definition and phenotyping, were more narrative domains. So no PICO for these domains, but a systematic review of the literature and a more narrative summary of the literature, while domains from 3 to 9 were mostly focused on the clinical ventilatory management of ARDS. So I will not say anything about definition and phenotyping because it's beyond the scope of this webinar. I just want to point out, let's go back here, that the definition domain was not intended to provide a new definition of ARDS. It was intended only to review strengths and weaknesses of the Berlin definition and to provide, let's say, a framework for a new multi-societal process on an updated definition of ARDS. But so we did not want to provide a new definition of ARDS. But let's see more specifically the recommendations from the clinical domains. So domain 3 and 4 were focused on non-invasive respiratory support. I'm not going to show you the forest plots here and the list of studies. I'm just summarizing the main recommendations. So, nasal high flow and non-invasive ventilation (CPAP) are superior to conventional oxygen to reduce intubation in both COVID and non-COVID patients, but what we had no clear indication of a superiority in terms of reduction of mortality. We were unable to provide a recommendation for or against nasal high flow compared to NIV CPAP to reduce intubation or mortality in non-COVID acute hypoxemic respiratory failure, while we gave a weak recommendation in favor of CPAP NIV versus high flow to reduce intubation but not mortality in COVID-19 patients. We also wanted to answer the question, which is the best interface for non-invasive respiratory support. So we wanted to compare helmet versus face mask. But as you may know, only one randomized study had been published at that time comparing helmet versus face mask as interface for non-invasive ventilation. And since it was a single center study on a relatively limited number of patients, even though it was published in JAMA, our methodologists felt that the strength of the evidence was not enough to provide a recommendation in favor of the helmet. So the fifth domain was on tidal volume setting. And the PICO question was whether low tidal volume ventilation alone, compared with more traditional approaches to ventilation, is associated with decreased mortality. So when we started the process, this was the domain that I thought would have been the easiest one, okay? Because everyone is strongly convinced that low tidal volume ventilation must be applied in every patient with ARDS. So with our surprise, at the end of the meta-analysis, as you can see from the forest plot, the diamond was crossing the identity line. So from a strictly statistical point of view, there is no evidence of a superiority of low tidal volume ventilation. So this was, again, a bit disappointing for all of us. And in the end, we are all convinced that we must use low tidal volume ventilation in every patient with ARDS. So in the end, as you can see there, we ended up with a strong recommendation in favor of low tidal volume based on expert opinion, despite the lack of statistical significance. So this was a sort of mediation that we found between the experts, the clinical experts, and the methodologists, who was, of course, more strict on the statistical evidence. But again, the main message was that that we wanted to convey was that we strongly recommend the application of low tidal volume ventilation, and we defined it as 4 to 8 ml per kilogram of predicted body weight compared to larger tidal volume to reduce mortality in patients with ARDS. So the next domain was on PEEP and recruitment maneuvers. Here you can see only a summary of these recommendations. Then if you want, we can discuss them more in details during the discussion. But in the end, we didn't find a difference in terms of reduction of mortality when we compared high or low PEEP strategy. So the meta-analysis was on the 3 largest trials on high versus low PEEP. The second figure was, should we set PEEP based on respiratory mechanics? And this was mostly esophageal pressure. So the meta-analysis comprised the 2 EpiVent trials plus the ART trial, which is not based on the esophageal pressure, but it's based on the concept of on the open lung approach. So recruitment maneuver plus decremental PEEP trial and PEEP set on the best compliance. In the end, we didn't find a superiority in terms of mortality reduction when PEEP is set based on respiratory mechanics compared to PEEP FiO2 tables. Then we analyzed the recruitment maneuvers. As you can understand, it's very difficult to separate the effect of recruitment maneuvers from the other setting of mechanical ventilation. I mean that in trials that explore the recruitment maneuvers versus no recruitment maneuvers, then there is also the effect of PEEP and tidal volume. But anyway, we decided to distinguish between prolonged recruitment maneuvers defined as the application of plateau pressure of above 35 centimeters of water for at least 2 minutes, or of brief recruitment maneuvers. And we ended up with a strong recommendation against the use of prolonged recruitment maneuvers that was mostly based on the findings of the ART trial. And this was mostly for safety concerns, so for the increased risk of barotrauma. While we did not recommend the routine use of brief recruitment maneuvers, but we wanted to underline, I want to underline the term routine, which means that we are not saying that recruitment maneuvers should not be used at all, but brief recruitment maneuvers can be used as rescue strategies in selected patients. We just wanted to highlight that we should not apply recruitment maneuvers in every patient with ARDS as a routine treatment. The next domain was prone positioning. And you can see there the list of studies that have been meta-analyzed. But as you can see from the red from the red square, the recommendation was mostly based on the result on the findings of the PROSEVA trial published by Claude Guérin in 2013 in the New England Journal of Medicine. And the recommendation is a strong recommendation in favor of the use of prone position as compared to supine position to reduce mortality of patients with moderate to severe ARDS. And so the point is that we should apply prone positioning in every patient who meets the criteria, the inclusion criteria of the PROSEVA trial, which is a PF ratio below 150 millimeters of mercury with a PEEP above 5 centimeters of water, despite optimization of ventilation settings. And this strategy has been associated with reduced mortality when prone positioning is associated with protective ventilation, so low tidal volume ventilation, and when the proning sessions last at least 16 hours per day. And this recommendation applies both to COVID and non-COVID patients. We also wanted to see whether awake prone positioning in COVID patients was beneficial, and we issued a weak recommendation in favor of awake prone positioning in COVID patients to reduce intubation. At that time, we had no data on mortality, or at least no evidence of an effect on mortality. And then what is very, very important is that we wanted to highlight that we should continue prone positioning in patients who meet those criteria, even if there is no improvement in oxygenation. And this is based mostly on a secondary analysis of the PROSEVA trial published by Albert in the Blue Journal in 2016, I think. This secondary analysis shows that the effect of prone positioning on oxygenation is somewhat disconnected from its effect on the patient outcome in terms of mortality. In other words, we just want to underline that not necessarily those patients who have experienced the highest benefit in terms of oxygenation with prone positioning are those who also benefit from the intervention in terms of mortality, and vice versa. So the idea is that we should start prone positioning in every patient who meet the criteria of the PROSEVA trial and continue prone positioning for at least 3-4 sessions. And we should not stop prone positioning because oxygenation does not improve much. So neuromuscular blocking agents, basically a recommendation against the routine use of continuous infusion of neuromuscular blocking agents to reduce mortality in patients with moderate to severe ARDS. Not due to COVID-19, and we were unable to give a recommendation in patients with COVID because there were no randomized studies comparing neuromuscular blocking agents, yes or no, in COVID-19 patients. So you can see there, most of the weight comes from, of course, the ROSE trial and the Accuracies trial. And since there was no statistical difference in terms of 28-day or ICU mortality, our recommendation was against the routine use of continuous infusion of neuromuscular blockers. And we will discuss this later. Last domains is on extracorporeal respiratory support. So the first PICO question was on the use of ECMO. If VV ECMO compared with conventional protective ventilation reduces mortality in patients with severe ARDS. And the meta-analysis was based on the study by Alain Combe, the EOLIA trial, and on the CESAR trial published by Gilles Pic in the Lancet. As you can see from the forest plot, there is a clear statistical significant advantage in terms of reduction of mortality for the use of ECMO in patients who meet the criteria inclusion criteria of the EOLIA trial. So this was a strong recommendation with moderate level of evidence, and also a weak recommendation in COVID-19 patients with a lower level of evidence. So 2 points on this. The EOLIA trial criteria, if you recall them, these are a PF ratio below 80 for at least 3 hours, a PF ratio below 60 for at least 1 hour, or refractory respiratory acidosis. And the second point, we wanted to underline that ECMO should be applied in centers which meets defined standards, especially in terms of experience of the people who are applying ECMO. The second PICO question was on extracorporeal CO2 removal. And here, the 2 trials that we meta-analyzed were the EXTRAVENT trial by Tom Bine and the REST trial by the group of Danny McCauley. And you can clearly see that there was no difference in mortality. So we issued a recommendation against the use of extracorporeal CO2 removal to reduce mortality. This was mostly based on, again, safety considerations. And mostly, you can see there the weight was 94% based on the findings of the REST trial. But we still think that that extracorporeal CO2 removal can have some potential in patients with ARDS. So our recommendation, we specified that this recommendation against the use of extracorporeal CO2 removal in ARDS is outside of randomized controlled trials. So we don't want to stop research on this. As I said before, few months later, the publication of the ESICM guidelines, the ATS published its own document. The aim of this document was completely different because the ATS only decided to update the 2017 guidelines on ARDS. So they just wanted to update the recommendations on the use of corticosteroids, ECMO, neuromuscular blockers, and PEEP plus or minus recruitment maneuvers. So in the end, they produced 5 updated recommendations plus 4 that were retained from 2017, and they did not want to make specific recommendations for COVID-19 patients. And so this is the summary of the ATS recommendation: a strong recommendation against prolonged recruitment maneuvers and HFO. A conditional recommendation in favor of neuromuscular blocking agents, VV ECMO, systemic corticosteroids, and higher PEEP levels, and a strong recommendation in favor of prone positioning and lung protective ventilation. So again, low tidal volume in the range of 4 to 8 ml per kilo of predicted body weight plus plateau pressure below 30 centimeters of water. This is a comparison of the methodology between the two documents. A much lower number of picos for the ATS compared to the ESICM. No difference because ATS did not give any specific recommendation for COVID-19. The number of authors was much lower, 24 authors in the ATS and 64 was the panel of the ESICM. We both followed the grade methodology. ATS had no voting because all statements had 100% of consensus. And for the ATS, only one patient representative was involved in reviewing the manuscript, while, as I said before, ESICM involved 8 patient and family representatives that were mostly involved in the selection of relevant outcomes. And what is also important, that 7 authors were in common between these two panels. So this is a comparison between the recommendations from ATS and the ESICM. So these are the recommendations that we agree on. So we agree for a strong recommendation in favor of low tidal volume ventilation, and a strong recommendation in favor of the use of prone positioning, and a strong recommendation against the use of prolonged recruitment maneuvers, as I said before. Then there is also an agreement on the use of VV-ECMO. Here the difference stands in the strength of the recommendation. So it's a conditional recommendation for the ATS and a strong recommendation for the ESICM. But what is more interesting, I think, and I will discuss this in the last 5 to 10 minutes of my presentation, are the disagreement between the recommendations, between these two guidelines. And the disagreements are on the use of neuromuscular blockade and on high versus low PEEP. And I will discuss this in details now. So the first disagreement is on PEEP. As I said, that the ESICM, we were unable to make a recommendation for or against high versus low PEEP strategy to reduce mortality in patients with ARDS. No recommendation, high level of evidence of no effect. The ATS suggests the use of higher PEEP without lung recruitment maneuvers as compared to lower PEEP in patients with moderate to severe ARDS. And why? How can this difference be explained? It's a striking difference, I would say, because we meta-analyzed the same 3 trials, so the alveoli, the express, and the other one from the NIH. So the same 3 trials, the same meta-analysis, and different recommendations. Well, the recommendation of the ATS was mostly based on 2 meta-analyses. And in particular on the meta-analysis by Brill that was published in JAMA that showed an advantage for higher PEEP in patients with a PF ratio below 200. The ESICM meta-analyzed the same 3 trials of the Brill meta-analysis, so more than 2,000 patients, but we decided not to do a sensitivity analysis based on the severity of oxygenation impairment. And so if you meta-analyze the 3 trials altogether, irrespective of the severity of the hypoxemia, you don't find any difference between high versus low PEEP, while if you do the sensitivity analysis based on the PF ratio below 200, you can find a difference in favor of higher PEEP. And this is why the ATS decided to produce a to give a recommendation in favor of higher PEEP strategy in patients with moderate to severe ARDS, while the ESICM, we were unable to give a recommendation in the entire population of patients. The second and probably more important disagreement was on neuromuscular blocking agents, because as I said before, the ESICM issued a recommendation, a strong recommendation against the routine use of continuous infusion of neuromuscular blocking agents to reduce mortality in patients with moderate to severe ARDS. On the contrary, the ATS gives a suggestion in favor of the use of neuromuscular blockers in patients with early and severe ARDS. It's a conditional recommendation, low certainty of evidence. So which are the reasons for this disagreement? Well, first of all, the PICO is different, because the PICO question in the ATS is, should patients with ARDS receive a neuromuscular blockade? While the PICO question with ESICM was, does the routine use of continuous infusion of an MBA in patients with moderate to severe ARDS reduces mortality? Then the ESICM focused its primary analysis on 2 trials, the ROSE trial and the accuracies trial, while the ATS included 7 trials. The number of patients is slightly higher in the ATS guidelines. And then what is also very important is the time point of mortality, because the ATS focused its recommendation on 28-day mortality, while the ESICM selected 90-day mortality as primary outcome. I go back to the previous slide, because what I want to underline is that we all agree that in very severe patients and in the early phases of ARDS, sometimes you need to use neuromuscular blockers to be able to ventilate a patient. So if you have a patient with white lungs and very low, very stiff respiratory system, very stiff lungs, it's basically impossible to ventilate them without neuromuscular blockers in the early phases of the disease. Our recommendation was against the routine use of neuromuscular blockers, and was against the routine use of continuous infusion of neuromuscular blockers. So we just wanted to underline that we should not paralyze with continuous infusion of drugs every patient only because this patient has a diagnosis of ARDS. But I think that we all agree that for more severe patients and in the early phases of the disease, sometimes neuromuscular blockers are necessary. And then if you want, we can discuss this a little bit more in depth later. So after the publication of the ESICM and the ATS guidelines, 3 editorials have been published in ICM. The first one was written by the 3 co-chairs of the ATS guidelines. The second one was written by the chair and the methodologists of the ATS. And the third one was written by Luciano Gattinoni. So with these 3 editorials, we tried to some way explain the differences, the disagreement between our recommendations, and to, let's say, provide the framework for the readers to understand these disagreements. And the main reasons, as I said before, were mostly explained by the methodological differences. So the 2 processes had different goals. So the ATS wanted to update the previous guidelines, and so focused on a relatively low number of PICO, while the ESICM wanted to establish a more comprehensive and wide process. As I explained, the PICO questions did not have the same formulation, and sometimes the precise formulation of the PICO question is very important to understand the differences in the recommendations. I must say that the ATS applied a little bit more strictly the evidence to decision framework. Also, the selection of the literature was different. I showed before that, for example, the meta-analysis of neuromuscular blockers for the ATS was focused on 7 papers, while the primary analysis of the ESICM guidelines was focused only on 2 main papers. There were some differences in the assessment of the certainty of the evidence and harm to benefit ratio, and very important, the selection of the outcomes. For the neuromuscular blockers, for example, if you look at 28 or 90-day mortality, this can make a huge difference. But I think that the main explanation for these disagreements stands in the opinion of the experts. And I'm citing here what Luciano Gattinoni wrote in his editorial, which is that when 2 expert panels sharing 33% of participants and the same evidence reach different conclusion, this suggests that probably opinions outweigh the evidence. And this is clearly demonstrated by, for example, the ESICM recommendation on low tidal volume. So these are my conclusion. Well, first of all, when we read the guidelines, we should not stick to the recommendation that is written in bold characters, but we should also read the explanation of the recommendation, because if you read the paper and if you read what the experts say, then you can really understand what is behind a certain recommendation. It's, of course, challenging to issue blanket recommendations that apply to all patients with ARDS, because we know that the ARDS is a very heterogeneous syndrome. So it's very difficult to give recommendation that can be applied to every patient that meets the Berlin definition criteria. Both panels underlines many times in their discussions that we need to individualize patient care. And this is my personal opinion. I think that we should make more effort more joint efforts to collaborate and to produce joint and synergistic clinical practice guidelines in order to avoid confusion and problems for the readers who are in the end stuck with sometimes not perfectly agreeing recommendations. So this was my last slide, and with this I thank you very much with your attention, and I will be happy to discuss this with Giacomo and the other panelists. Thank you.
Thank you very much.
Thank you. Thank you so much, Giacomo. That was super clear and very synthetic on a wide topic. So maybe I don't know what my colleagues suggest. I would start with the questions from the chat and read some of those, and then perhaps we can add some.
Yes, yeah. Okay.
Yeah. So one question is about prone position. The question is what's the duration of the prone position? And I think some evidence came out after the guidelines, but still the guidelines, of course, are a little bit more conservative. And I'm not sure if there's any mention, I don't think so, but maybe you can elaborate on this, on the role of neuromuscular blocking agents during prone position. So duration and combined use of neuromuscular blockers.
So for duration, well, the guidelines clearly say that we should, well, we analyzed we based our recommendation mostly on the ProSEVA trial. So we followed the methodology of the ProSEVA trial that was at least 16 hours per day. And this is what we do, I have to say, in our everyday clinical practice. So what we do practically is that we tend to prone the patients, let's say early in the afternoon, and then we put them back to supine position the following day at the end, more or less during the morning. Okay, so we apply this 16 hours recommendation. Then there is some evidence that came mostly from COVID, and then something also afterwards that also even more prolonged sessions of prone positioning may be beneficial. So in some patients who are particularly difficult to ventilate or particularly we think that should really benefit from prone positioning, but we don't see immediately the response after the first hours of proning. Sometimes we decide to keep them prone for a more prolonged periods of time, even 24 hours. Of course, you have to balance with the risk of, pressure source, eventual hemodynamic instability, dislodgement of catheters and so on, and tubes. But it's feasible. Sometimes we decide to extend from 16 to 24 hours. But I would say that the recommendation is to stick with the 16 hours. I don't know if Giacomo, if your experience is the same or not, but this is what we do in our clinical practice.
Mhm.
And
Yeah, I have to say that after the COVID, we are getting a little bit more confident in using more extended prone position. There's a question in the chat, 16 up to what? And I think there's really up to whatever it's been used like 48 hours during COVID,
Mhm.
but we don't do that now. But we also tend to keep the patients like I would say it's more often 24 hours. It's also logistical factors, and there are studies, right, showing that theoretically the longer the better is the outcome, but still it's a kind of observational studies, and so it's just a matter of association. And I would say that in our clinical practice we almost always paralyze the patients when they are prone. This is
Yeah.
not covered by guidelines, but perhaps you might want to share something like from a more let's say personal experience.
Yeah, and it's exactly what we do. I mean, we paralyze them. Well, first of all, because usually during propositioning, you also need to usually you need to increase also the level of sedatives,
Yes.
and the idea is that during they are prone during the early and more severe phases of disease. So the idea is that with paralysis, you are, let's say, you have full control of the ventilation of the patients, of the volumes and the pressure that you apply to the patient. And also for safety reasons, you also avoid, I don't know, like coughing that can lead to, let's say, secretion mobilization and tube obstruction, or movement of the patient with again, dislodgement of tubes, drains, catheters, so on. I agree with Giacomo. When we prone the patients during the early phases of the disease, we always paralyze them. I just want to make another very short comment on prone positioning is that we tend to say that patients are responded to prone positioning because they improve oxygenation. I have just completed a meta-analysis, a systematic review of the literature together with Claude Guérin on this because there is a very huge heterogeneity on how response to prone positioning has been defined. Not even if you stick with oxygenation, there are, I mean, the response in terms of oxygenation has been defined in several ways. Let's say percentage increase in PF ratio, or an absolute increase in PF ratio or PO2, or even a change in PO2 after return to supine position. So what I'm saying is that the idea is that prone positioning is beneficial, not really because it improves oxygenation, which is of course a plus, and it's something that we all like, but it's because probably it allows more protective ventilation or more, let's say, even distribution of ventilation. So that's why we in the guidelines we suggested to apply prone positioning in every patient with the ARDS and the criteria of the ProSeva trial, even if you don't see a major improvement in oxygenation during the proning session.
So,
Giacomo. Oh, sorry. Go ahead.
no, it's okay. It's okay. I'll hear.
No, because there's other questions on prone position and MBAs, but just to try and be a little bit broad in terms of topics, there are also many questions, as you can imagine, in regard to, I would lump them, PEEP setting and recruitment. You mentioned that ESICM guidelines are very, let's say, vague in terms of PEEP setting. Basically, they say do whatever you want. If I can ultra summarize this, ATS guidelines are a little bit more, let's say, explicit, but probably I think colleagues, would you like if you could elaborate a little bit further on how we could, let's say, interpret the guidelines and bring them at the bedside?
Yeah. So okay, both guidelines more or less focus on the three largest trial comparing high versus low PEEP. And again, between these trials, the high versus low, what was high PEEP and what was low PEEP was different, of course, and two trials were based on different levels of PEEP FiO2 tables, while the Express trial by Alain Mercat applied in the high PEEP arm applied the higher PEEP level that allowed to reach 30 centimeter of water of plateau pressure. Okay, so and these three trials, if you recruited in total more than 2,000 patients, and if you analyze the results on the entire population of patients, you don't see a difference in terms of mortality. Then if you, as it was done by the ATS, if you do a secondary analysis, a sensitivity analysis of the subpopulation of patients with more severe ARDS, then you see an advantage for higher PEEP compared to lower PEEP in terms of mortality. And personally, in my clinical practice, and I think also in Giacomo's, the more severe is ARDS, the higher, more or less, is the PEEP level that we tend to apply. The problem with PEEP setting is that we should try to tailor, to personalize PEEP setting in each patient based on the pathophysiology of its disease. So it's not only a matter of the severity of hypoxemia, it's also a matter of how compromised is the compliance of the respiratory system, and if the disease of that patient has a higher or lower potential for lung recruitment. So if you read the chapter on PEEP and recruitment maneuvers, the discussion on that you can find in the ESICM guidelines, this paragraph was written specifically by Luciano Gattinoni, and if you read it, you will see that okay, the recommendation is there is no difference between higher and lower PEEP, but then if you go a little bit deeper into the text, then you will see that we all advocate a more personalized PEEP setting, mostly based on the pathophysiology of the disease of each patient. But if we just stick to the question on high versus low PEEP, in my clinical practice is that patients with the more severe is ARDS, the higher is the level of PEEP that we tend to apply, especially in patients with low respiratory system compliance and higher potential for lung recruitment. Of course, remaining within safe thresholds of plateau pressure and driving pressure, which is not mentioned in the guidelines because at the moment, there are no randomized studies focused on driving pressure guided mechanical ventilation. We are now there is now a very large randomized study, international randomized study led by Ewan Gallagher and the University of Toronto, personally, I think that driving pressure is a very sound, physiological target also for tidal volume setting. But that's my personal opinion. It's not supported by evidence coming from randomized studies.
Can I add a question regarding PEEP in obese patient? Sometimes when we use esophageal balloon in patient obese, we detect higher PEEP. So in that case, how can you deal with that?
Yeah. No, I mean it's a very good question, and I think that again the guidelines meta-analyzed the two EPIVENT trials. As you know, the first EPIVENT trial, well, first of all, the EPIVENT study, the EPIVENT methodology looks at absolute value of esophageal pressure, and the goal is to keep slightly positive and expiratory transpulmonary pressure. So the difference between and expiratory airway pressure and esophageal pressure should be 0 or +2, +4 centimeter of water. This is what was done in the EPIVENT 1 trial, and that was published in the New England Journal of Medicine on a low number of patients. The comparator was the low PEEP-FiO2 table. Okay, so in that study, the PEEP set based on esophageal pressure was significantly higher than the PEEP set in the control arm, and there was a significant advantage in terms of mortality for PEEP set based on esophageal pressure. Then the EPIVENT 2 study repeated more or less the same study, but in the control arm, the PEEP, they used the higher PEEP-FiO2 table. So there was no difference, but if you look at the PEEP levels in the two arms, it was the same. So it's not difficult to understand why there was no difference. Okay, so if you meta-analyze these two trials together, and the second one recruited a much higher number of patients, then you don't find the difference. But of course, there are situations like morbidly obese patients or patients with very stiff chest wall, in whom a PEEP setting based on esophageal pressure, or at least a study of partitioned respiratory mechanics, is certainly has a very, very sound physiological rationale. Because in those patients, you can apply plateau pressures of 40, 45 centimeters of water, but then if you calculate transpulmonary pressure and inspiratory transpulmonary pressure, then you can find that you still are in the safe range of transpulmonary pressure. Okay, so I agree with you in morbidly obese patients, or in patients with very stiff chest wall, or in every patient in whom we need to apply very high PEEP level because we feel that there is a huge contribution of the chest wall. Then in all those patients, we tend to put an esophageal balloon and then to use that also as a method to set PEEP. Then we can discuss if you want to use the absolute value of esophageal pressure or the elastance ratio. Then that's another point. But I agree that in some when you think that the chest wall is very stiff, then and you need very high PEEP levels or higher than recommended plateau pressures, then you should probably monitor esophageal pressure to target your ventilation on transpulmonary pressure rather than on airway pressure.
So, I just would like to ask you about a question, a general idea about how do you balance regarding the heterogeneity of the ARDS and the different phenotypes. How do you balance between the follow-up of the guideline recommendation and the individualized management of such a disease? I don't think it's a single disease anymore, but
No.
how do you balance between those two?
No, I agree with you. It's not a single disease, it's a syndrome. So by definition, it's not a disease. And it's been clearly demonstrated that there are subphenotypes of ARDS,
Yes.
and you can subphenotype the disease based on the radiological appearance, or based on, let's say, respiratory mechanics, or based on biomarkers. And for example, based on biomarkers, you know that there are hypo and hyperinflammatory subphenotype of ARDS. They respond differently to different levels of PEEP, to different strategies of fluid management, or even to some drugs. So I completely agree with you. It's not a single disease, it's a heterogeneous syndrome, and we should really dive into this. The point is that the guidelines are made for, let's say, to give general recommendations that should be applied by more or less everyone in order to, let's say, be safer. Okay. And so if you say that you should apply low tidal volume, plateau pressure below 30, or probably in the future, a protective tidal pressure and let's say a reasonable level of heat, then you don't hurt anyone. But I agree with you that since it's a heterogeneous syndrome, what we should do is try to characterize the patient from a pathophysiological point of view, and then try to tailor the ventilation on the pathophysiology of each single patient, or at least of each subphenotype of the disease, of the syndrome, sorry. So it's very difficult to balance. In our, let's say, everyday clinical practice, we never set PEEP based on PEEP FiO2 tables.
Yes.
We don't even have the PEEP FiO2 tables in our at the bedside, okay? And of course, we set tidal volume. We use a protective tidal volume, but sometimes we go higher with plateau pressure because, as we were saying before, we have transpulmonary pressure monitoring, or sometimes we accept even a slightly higher tidal volume because driving pressure remains within safe, or what we think it's safe limits. So probably guidelines are meant to give general recommendations, but then at each patient level, then you should be a little bit more, let's say, focused on the pathophysiology of the disease. But this requires, measuring of respiratory mechanics and some things that sometimes cannot be done everywhere by everyone.
Another question is, as you are the main author of the guidelines, mechanical power or ventilator-induced lung injury, usually the most important part in it is respiratory rate. And this is not mentioned in the guidelines, and all of the guidelines since ERDS network mention low tidal volume only.
Yeah.
So,
well, the point is, low tidal volume means low tidal volume, low plateau pressure, okay? Because let's say the ARMA trial, the two arms were 6 versus 12 ml per kilo and 30 versus 50 centimeter of water of plateau pressure, okay? So when we say low tidal volume, we mean low tidal volume, low plateau pressure. The mechanical power was not mentioned exactly as driving pressure was not mentioned, because there are no randomized studies. Okay, there are no randomized control studies that focused on ventilation setting based on mechanical power or driving pressure as a target for the ventilation. I think that I don't use mechanical power so much in my clinical practice. I think that the mechanical power it's clearly an interesting concept, especially because it in some way underlines the effect of respiratory rate and some also of inspiratory flow, which is something that we tend to neglect. But again, also in the mechanical power, the most important parts are tidal volume and plateau or driving pressure. So it's another way to compute the intensity of mechanical ventilation. I don't know if it makes a real difference when you want to set mechanical ventilation, but that's my personal opinion, and I like to hear yours or Jacqueline's one.
Yeah, no, so personally, I think in the guidelines, as you said, I was also an author on the guidelines, and so I think we missed a little bit an opportunity to at least mention driving pressure. I think without saying, oh, you should target mechanical ventilation on driving pressure, like a strong statement. But when you we gave a recommendation, tidal volume 4-8 ml per kilo, it's 100% range. So it means that you're fine with 320 or 640 tidal volume. So I think saying monitoring parameters such as driving pressure, something weak, but at least to put it
No,
there,
no, I know
would
it's not
have
in the
been,
recommendation. It's in the paragraph below,
yeah,
but it's not in the recommendation. That's why I
sure.
was saying try to read.
Yeah, yeah, no, okay. Uh, and the other point is I am yeah, I have a bit of a hard time with mechanical power because, as you say, it puts together many many things, and
Lot
so
more.
it's a little bit hard to disentangle the role of the different aspects, and so PEEP and so personally, I really use driving pressure a lot at the bedside, a little bit less other. I'm not using mechanical power actually. Not because of it is complex, but honestly, I have a hard time interpreting the meaning because sometimes you can just manipulate easily mechanical power without really affecting the ventilation on the lungs. That's my opinion.
Thank you. I think there's another question about the different moods and the choice of moods in ARDS. What's the preference of the moods and use of non-conventional modes or closed loop modes or APRV even in ARDS? So what's your opinion on what does the guidelines recommend in different
No,
modes?
there is no
No preference.
in the guidelines. There is no recommendation on the mode.
Yes.
So if we stick to, let's say, controlled modes of ventilation and standard modes of ventilation, personally, I think that we can discuss for 1 month about volume versus pressure control ventilation.
Yes.
I think that it doesn't make such a big difference
Difference. Yes.
provided you know what you do with your ventilator. So if you want to go with pressure control, you should set an alarm on tidal volume and vice versa. Uh, what we do, I can tell you what we do in our clinical practice. At the beginning of the ventilation, in the very early phases of the disease, especially in patients with low compliance of the respiratory system, we tend to use volume control ventilation. Then when we
Anyway.
stop neuromuscular blockers, we tend to switch to pressure control ventilation or acid pressure control ventilation just because if you allow if the patient is not paralyzed anymore and has a, let's say, high
Flow.
respiratory drive, then he needs he needs
Flow.
the flow. And so
Yes.
with pressure modes of ventilation, we have a peak flow and then an accelerating flow, while with volume control ventilation you have a flat constant flow. And if the patient has a high respiratory drive and the flow is not enough, that's a very big problem with the patient and the huge increase of work of breathing. So in the very early phases of the disease, we tend to use volume control and then we switch to pressure control when we stop paralysis. But that's again
Practice.
our practice.
Our
A
practice.
PRV, I do not have much of experience with the PRV. If you invite for a webinar Luigi Camparotte, who will explain to you a PRV. If you hear Luigi Camparotte talking about a PRV, he will convince you that a PRV is the best mode that you can apply.
Yes.
And since I trust Luigi a lot, I think that it's interesting. It's an interesting mode. In some groups, for example, the group of Alain Combe applies a PRV during ECMO. So the mode of ventilation during ECMO is a PRV, which is basically a two-level CPAP. So it's basically the ventilator shifts from two levels of PEEP, allowing spontaneous breathing at both levels of PEEP. So it's a very interesting concept. I do not personally not have much clinical experience with that. Closed loops like NAVA, for example, PAV, I don't know, these are more, let's say, closed loop for spontaneous breathing. It's those two, and we use them sometimes during the weaning phase of ventilation. I don't have a lot of experience with other closed loop ventilation, like IntelliVent ventilation, for example. Especially in the more severe phases of disease, I think that we should set ventilation based on physiology of the patient and not let the ventilator do that. Why they are very interesting or useful probably during the weaning phases of or in more or in simpler patients. In patients with severe ARDS, I would not. I don't know. Maybe I'm biased, but I like to. And I like to select my ventilation setting rather than letting the ventilator do it. But again, if you
I do the
invite
same.
Dr. Schultz, he will tell you that these are very, very smart modes of ventilation. So,
Do you have experience of bioelectrical impedance during mechanical ventilation?
so you have experience of?
Bioelectrical impedance
Yeah.
for the lung?
I have experience. Giacomo has.
Yeah.
IT.
Yeah. Please, Giacomo, go ahead.
Yeah, no. Well, now in Trento, where I work, we don't have EIT, but we used to have it and use it quite a lot in Monza. And yeah, I mean, personally, I think it's something that has, in a way, its own guidelines, and so I would say it definitely is something that could add insights, could add, let's say, a fine tuning of beep. Again, I don't think we will get to the point, well, at variance from driving pressure, let's say. I don't think we will get to a point where we will have trials showing that EIT is superior to other techniques in setting PEEP. If we are looking for this, I think forget about it. It's a monitoring technique, and just any monitoring technique. It depends how you use it. But in some selected patients, it definitely gives insights. For example, on the lung recruitability. Is it a must-have? No, for example, we don't have it. Sometimes I wish we would, but we don't. It's, I would say, a nice to have, and probably if you're a center, an ECMO center, for example, then it's something that you definitely would like to have more.
Yes, we use it again to assess the recruitability and sometimes to set PEEP. But again, as Giacomo was saying, it's a monitoring tool, so you need to interpret what you get from this monitoring tool. To give you an example, we had a very difficult patient a few days ago, a patient with ARDS plus asthma. So it was both like overinflated and also collapsing some. And we tried to and we wanted to select the PEEP level. So we did it with esophageal pressure, and then with EIT, and esophageal pressure said 18, and EIT said 10. So again, it's a monitoring tool. In the end we did 14, so it's not in the middle, but it's very not probably not for every patient. It's not the panacea for everything. In some patients, it gives you some information, and especially on the distribution of ventilation, and sometimes it allows visualization of what you are doing. Probably more. I know that some people will hate me for this, but probably more than ultrasound. I'm not very good with ultrasound, but these are very, very operator dependent.
Yes.
Even though I understand that, especially in, let's say, low resource settings, for example, lung ultrasound may be of great help, and some advocate the introduction of lung ultrasound in the definition of ARDS.
Yes.
So, as Giacomo was saying, these are monitoring and imaging tools, and then you need to interpret them.
Yes.
Okay, we have okay.
Go ahead,
We have
Stefan.
only question. Time is running, but we have question regarding steroids dose and duration if you use it in ARDS.
Duration of what? Sorry.
Steroids,
Steroids.
corticosteroids.
So in the ESICM guidelines, we didn't want to discuss pharmacological therapies. So we specifically didn't want to discuss steroids, while these were discussed in the ATS guidelines. And the ATS guidelines gave a recommendation, a conditional recommendation in favor of the use of steroids in the early phases of disease. As you know, there was also a study by Jesus Villar that uses dexamethasone for the first 8 to 10 days. And in that study, it was steroids were associated with reduced mortality. And based on that, then dexamethasone was used in COVID patients.
Yes.
There is also evidence that steroids can be beneficial in community-acquired pneumonia, in severe community-acquired pneumonia, even though the evidence is not completely in agreement. So, if I should tell you what we do, we don't use steroids in every patient with ARDS in the early phases of disease. We tend to use them more in patients with unresolving ARDS, so in later phases of the disease, especially in patients with tendency to fibrosis or, let's say, to reduction of compliance, except for specific indications like, let's say, COVID, for example. And now we are starting to use them in some cases with severe community-acquired pneumonia, especially in patients with a history of COPD or some obstructive lung disease, not for ARDS per se as primary indication. But again, this is mostly based on our own experience, and the literature is probably not let's say not in complete agreement, but there are studies suggesting the use of steroids. Indeed, the ATS guidelines, and Giacomo was part of them, give a recommendation in favor of the use of steroids. So,
yeah, a recommendation in favor, but very vague. I mean, steroids, yes, but
yeah,
what
we don't know which steroid, how to taper them, how to administer them. For example, the last study on community-acquired pneumonia was on hydrocortisone. Other studies point of methylprednisolone, dexamethasone, so completely different molecules, dosages. So if you like them, probably the evidence points towards dexamethasone for the first, let's say, 8 to 10 days. Something similar to what we did with COVID-19, based on the study by Jesus Villar. But I don't have a recommendation, a strict recommendation on this.
Okay, time is running, and actually we have many questions, but I think can we have received another, or your time?
No, we can.
Okay, there is a question about ECOR in ARDS, CO2 removal devices. What's your experience about it?
My experience is exactly that of the guidelines. So I tried some devices that are specifically designed for extracorporeal CO2 removal. So devices that run with low extracorporeal blood flow, let's say below half a liter per minute or around half a liter per minute. I think that these devices can remove up to 60, 80 ml per minute of CO2, which is, let's say, about 1/3 of the average metabolic CO2 production. In patients with ARDS and hypoxemia, I personally don't see the advantage of using low-flow extracorporeal CO2 removal devices. With the Supernova trial, we have shown that it's probably more useful to go with higher blood flows, even if you stay with blood flows lower than those that you apply with full ECMO. But if you go with 1.5 liter per minute of extracorporeal blood flow, then you can remove more or less 80% of the total CO2 production, which means that you can significantly reduce the ventilation that you apply to the natural lung. Again, if the patient is severely hypoxemic, I don't really see the advantage of using an echo to R devices compared to ECMO, because you have all the disadvantages, which is anticoagulation, and none of the advantage, which is the improvement in oxygenation. So if you have ECMO capability in severe ARDS, to me, there's no point for using lower flow
Echo.
devices. If you don't have ECMO and you want to remove a significant amount of CO2 to reduce a lot of the intensity of ventilation that you apply to your natural lung, then you need to go to at least 0.8, 1 liter per minute. Lower flows are very good for, let's do what one of my friends used to say, that low flow are good for black lungs. If you have white lungs, low flows are not very good.
Yes.
Yes, I have another question about weaning of ARDS patient. Do you have any evidence about something specific for this patient? We saw a lot of patient with a relapse during weaning.
Well, the problem is it's not a relapse of the disease. It's probably, unless they have, let's say, a secondary infection. But if it's a relapse in terms of worsening of oxygenation and compliance during weaning, it's probably because it's very, very difficult to switch to understand when it's the right moment to switch from controlled to assisted mechanical ventilation. And Giacomo is probably one of the biggest experts on this. When you switch to assisted mode of ventilation in patients with relatively high respiratory drive, like patients with ARDS, then you need to monitor them very carefully, because it's very easy to let them develop high non-protective tidal volume and transpulmonary pressure swings. So the problem is that if you want to keep a patient with ARDS, again, white lungs, with an assisted mode of ventilation, then you need to monitor them. You need to monitor the drive and the effort. You cannot do that only based on tidal volume or respiratory rate. It can be completely misleading. I think that you all know the iceberg picture that Giacomo shows at every presentation on this. So what you see on the ventilator screen is only the part of the iceberg which is outside the water, but there is the whole part under the water, which is the work that is done, the pressure that is applied by the patient muscle, that can translate in very dangerous and injurious transpulmonary pressure swings and tidal volumes. So I think that that's the main problem.
So I think we had a very good night with you, Giacomo and Bilani and Gracili. Thank you very much for your great speech today, or talk today.